honorable guests, and dear patrons. Assalamu alaikum and a very good evening to everyone. I'm Wasif from Sanavia Pharma PLC, and it is my absolute pleasure to welcome you all to our today's symposium on innovative approaches in gastric cancer, a patient-centric care with better outcome. Synovia Pharma PLC, formerly known as Sanofi Bangladesh Limited, has been a pioneer in introducing the oncology molecules in Bangladesh, and since our inception, we have remained dedicated to sharing the latest advancements in cancer management, fostering collaboration with esteemed professionals like you all, just to ensure the better patient care. As we are all aware, the incidence of gastric cancer is increasing with time, and so does the advancements in its management worldwide. And there couldn't be a more fitting platform, just like 19th SFO BICC 2024, to deal these developments. With this opportunity, we aim to facilitate the exchange of knowledge on the most recent innovations in gastric cancer management. Today, we are honored to have Dr. Carmelo Pozzo as our distinguished speaker. Dr. Pozzo currently serves as a consultant at the Fondazione Policlinico University and a professor of medical oncology at the Catholic University of Sacred Heart School of Medicine. His extensive research focuses on novel drugs for the treatment of gastrointestinal tumors and identifying prognostic factors in gastrointestinal cancer. So without further delay, I'd like to invite Dr. Carmelo Pozzo to take the stage and share his valuable knowledge. And there's another thing I should say, that there will be a quiz, there will be quiz questions in between his lectures, and we'll declare the winners accordingly. So thank you. It's all up to you, sir.
Thank you for the invitation. It's the second time for me here. It's always a great pleasure to be here in Bangladesh, although it's a long trip from Rome, from the Vatican, from the rest of the world. But I'm really very glad for this invitation, and I thank Synovia for giving me the opportunity to talk about one of the subjects of my career. Colon and gastric cancer are in my heart for several years now. And I hope I can give you more insights in what we are doing in the rest of the world, in my part, but also hopefully in Bangladesh. So let's start. I want to start presenting myself. I work in a bigger hospital. It's a huge, one of the biggest hospitals in Italy, and this is important for us. I will tell you why. Because it's quite crucial, the high volume of patients you have to give to the patient the best quality. I was listening to that yesterday about the surgical course and so on. I see the number of patients you see gives the idea of the way you work. So, but in my center is the highest volume center in Italy for GI cancers. So we have a long and a deep experience, and we have many trials ongoing. I hope some of these trials can also be extended also to you if you want. So this is the overflow of my intervention. There will be a kind of educational approach, but with newer indication, newer drugs, newer chemotherapy approach, like they asked me from Synovia. It's a little noisy. Can we have some more silence? This is my flow. I will start from epidemiology, hereditary syndromes. I will touch really a few words for any single points, because otherwise it would be too long. It will be a 2 days course. And I will finish with the treatment of locally advanced adjuvant and metastatic disease. So as you know better than me probably, the gastric cancer is the 5th most common cancer worldwide, and the 4th most common cause of cancer death in all over the world, with 1 million cases per year. What do we have in your, is there a point? In your area, actually, it's very close to Italy, to some part of our European countries, where we have a higher incidence of gastric cancer, but it's not as high as the Eastern Asian country. As you know, in Japan, they have the highest incidence of the rest comparing to the rest of the world, and also in Latin America. But what is important to know is that They have, in any kind of the world, in any part of the world, we have different incidents of different tumor types. For instance, the lower part, the non-cardiac gastric cancer, is most common in this area, in East Asia and Latin America, and represent the 80% of the all gastric tumors. And it's important in epidemiological factors, the infection of Helicobacter pylori, the alcohol abuse, and the high salt intake, which is typical of that area. And in our country, in the Western world, maybe also here, the proximal cardiac, the upper part, is more common, and it's due mainly to obesity, to the disease of the of Western world, obesity and gastroesophageal reflux. There are also some familial aggregation. You know, it's not, we cannot talk about the full hereditary cancer, but there are at least 10% of cases where there is a familial aggregation. You know, when you have in front of you a patient with gastric cancer, especially if he's a young patient, with a history, family history of several cancer types, you always do your best to understand if there is a familial risk, how, from what gene mutation depends this familial risk. Actually, there are very few cases where it's a real hereditary cancer. However, there are many cases where the familial risk can be detected through the mutation on certain genes. You know that now it's a fancy to have this genome profile, a full profile. We have a trial in my country it's called with 500 genes, but you can easily find on the internet with only 40 genes, very cheap. You can do it also from home. They can send you the specimen. And it's important to understand what kind of genes you find. The most common is the APC you see here. But basically, we don't know what is, it's not like a pancreatic cancer or breast cancer where BRCA1 and BRCA2, it's certainly involved. But when you have some mutation in the family, always be very attentive to what happens to your patient, especially if he's a young patient. So, going through classification, it's absolutely important, this first part, because this is the driver of all the treatments, classification, staging, and so on. It seems there is something for students. It's not for students, believe me, because I do this class for residents and for other doctors in Italy, and sometimes they don't understand, they don't remember that this part is absolutely mandatory to have to make a decision, the right decision process for the patient. You know, the gastric cancer is now, at least in my latitude, subject of any MTD, any multidisciplinary meeting, starting from the diagnosis until the palliative care. And these are news you have to give to the MTD to understand what you can do for your patient. I don't go into details of the classification. I just wanted to let you see. Okay. This is just from the past, you know, but still you see in your pathology report also this indication. But what is important for us to understand the Lorentz classification, if it's intestinal diffuse or mixed type, because this is related also to prognosis, to certain biomarkers, to certain drivers. And this is the most important and most recent. If you the good quality, I don't know if there are some pathologists here in the audience, but the good quality pathology report has to report also this classification, where you see if it's a tubular, papillary, or poorly heavy. You see in this group is the famous signet ring cell carcinoma is the type of gastric cancer with the worst prognosis, as you know very well. And the other important issue is what's the biological behavior? What's the molecular characteristics? What are the molecular characteristics of gastric cancer? Maybe you have seen this picture also from colon cancer. This is an important, absolutely crucial and important paper you have to download if you don't have it, because it's a threshold. From that point on, the precision medicine has totally changed. It's 10 years ago, roughly, but still very modern. And in a group of 250 or 240 patients, if I remember well, they've been classified in 4 different groups. Chromosome instability with intestinal histology, some kind of mutation like RAS or PT53, and the genomically stable with diffuse histology usually, and a specific mutation of Claudin, which is important now for a new drug, a newcomer arriving in the market. And the 2 groups of Epstein-Barr virus and MSI, which are the 2 groups of gastric cancer that respond to immunotherapy. You may say, okay, how can I have this classification? I know, it's very hard, and this will be part of the next study design, but in our practice, we started to ask the pathologists to give us an idea, for instance, of the Claudin, or to give us an idea of the expression of Epstein-Barr virus, because it has an impact also on the treatment. What do I have to know from a pathologist when we have a diagnosis of gastric cancer? For sure, F2 overexpression. You will see that this is another mandatory biodriver, PD-L1 expression in a combined positive score. Don't confuse CPS with TPS. It's a different situation because one is percentage, the other one is the number of cells. Microsatellite instability, of course, like in colon cancer and also other tumors. Then there are other biomarkers, but you will hear a lot about that, in particular about FGFR2 amplification or Claudin 18.2 overexpression, because these two drivers already are druggable. You will see in the next ASCO meeting, there will be some surprise on that. So let's move just a few words on the staging, because you are very well trained and you know everything about that. Now, what do we need for gastric cancer? Sometimes you receive simply diagnosis, adenocarcinoma. It's not enough. I need to know more of that. Not this before the operation. We need at least 5 to 8 multiple endoscopy biopsy. At least this is the good quality of the endoscopy. As I heard, as you know, we need these 3 factors. So even if it's only biopsy, you have to know HER2 expression, PD-L1, MSI, or mismatch repair deficient. This is part of the pre-decision, let's say. In Europe, we have this SCAT, it's ESMO. Today, I was listening to the guidelines. Nobody was talking about ESMO live guidelines. No, for us, this is very important, actually, because ESMO is doing a good work, and I will make a connection if you don't have it, because it's not only NCCN guidelines that we are following also ESMO and ASCO. And ESMO, the quality, the good quality of ESMO guidelines is that they are updated lively. So if you go on the internet, you find the last update. This is very important for biomarkers. You see, biomarkers in gastric cancer, we have it at this level. So it's a level 1A, 1B only for 1. What about the diagnosis? Endoscopy, we are talking about that. CT scan, it's mandatory. I want to emphasize 2 different points. One is ultrasound, endoscopy, ultrasound, laparoscopy, and last but not least, the nutritional assessment. Yesterday, I've heard just a few words on nutrition. Why endoscopic ultrasound? Endoscopic ultrasound, you need it to understand how, if there are really, there are nodes, or you need to understand the deepness of the tumor. Sometimes you cannot split from T1 from T3, simply because the CT scan doesn't help about that. And you know that there's a difference in the decision-making process from a T1 to T3. And the second point is staging laparoscopy. Staging laparoscopy, of course, it's not available in any centers. Luckily, in my centers, we've been working a lot on that. And laparoscopy is part of the diagnostic procedures. Why laparoscopy? Because when you have peritoneal carcinomatosis, not detectable by CT scan, you cannot give to the patient a perioperative treatment. It's not a locally advanced disease. It's an advanced disease, and you cannot treat with float whatsoever in a perioperative setting. The rest you know very well. They told me that to put some questions in between. So, and the winner will be the one who raised the hand first. So you can read what immunohistochemistry and molecular features are mandatory for choosing the first-line therapy in metastatic gastric or gastroesophageal cancer. This you have seen is the triplet. Yesterday they say the 3 musketeers, but these are musketeers as well. Only HER2, only MMR, mismatch repair deficiency or MSI, or PD-L1 TPS. Okay, there. A. May I say that it could be correct, but I'm not sure? Because you need HER2 from the beginning. No, it's correct. But if you don't have HER2, you cannot, even if you have...
HER2, PD-1?
It's A. Why I put the slides? Because there's always a confusion. When you have PD-L1 more than 5, even more than 10 CPS, and you have HER2 is always the winner. So you start first from HER2, at least so far with the level of evidence we have, and then you decide based on PD-L1 and so on. But we will see later. You will get confused. Let's start now with the treatment, locally advanced disease. These are the new guidelines, ESMO guidelines. And you see that there is some little change compared to the past. 2 years ago, this was the subject of my talk. I can say that something has changed. In particular, at this point, and I will tell you why. Of course, if you have a stage one, it's T1 and 0, M0, you go directly to either endoscopic, they're either also for a little superficial, there are endoscopy guidelines. They say that endoscopy, sometimes it's enough, so you don't need to operate all the patient when it's a very superficial lesion, less than T1, TES, and so on. But when the stage is more than T1, let's say stage 1B to 3, you have to put the patient in this algorithm, in the multimodal approach. Of course, this is the strong and the fight in MTD meeting, because surgeons, they want to operate immediately, and radiotherapists and oncologists, they want to treat the patient in a perioperative setting. So what is the change between now and last year? Because 2 years ago, this was T2. It was starting from T2. So now we incorporated even T1B in the ESMO guidelines. I don't remember if NCCN did the same, but at least in Italy, we treat all these patients from T1B with a preoperative approach. So we anticipate the chemotherapy in a preoperative chemotherapy, surgery, and postoperative chemotherapy. So this is the algorithm you know very well, with the FLOT4 cycles, 4 cycles here, the gastrectomy and postoperative chemotherapy. However, there's a big group of patients. Don't consider even in my country, where we are supposed to be the best in the world, Italians. So there are many patients that are operated from the beginning. Why? Because surgeons, in many cases, do not accept this approach. So for a T1, for instance, they operate immediately. They don't even send you the patient for a oncology consultation. And, or the patient for a severe anemia, or for, I don't know, kind of obstruction, he couldn't swallow, he couldn't be in a good nutritional status, was operated immediately. In this case, whatever it is, when we have a T2, T3, a T4, and NEN, the patient has to receive an adjuvant postoperative treatment. I go very quick now because there are many studies, otherwise you get bored. This is the standard of care. FLOT, it's been presented some years ago by Albatran from Germany. FLOT4 4 cycles and 4 cycles after surgery compared to ECF. You know very well the overall survival was much better in the FLOT4 arm, even PFS and overall survival, with highly statistically significant improvement. So this became the standard of care. However, there is some problem with FLOT. FLOT is a very toxic and aggressive regimen. Sometimes you are not able to give to the patient. The first part, usually you made it. But the second part, the postoperative, only 60% of patients are able to finish all the perioperative plan. Maybe we can do something on that. We will talk about that later. What happens in the neoadjuvant treatment? Perioperative. Unfortunately, all the attempts of immunotherapy or integrating immunotherapy and R2 trastuzumab were not efficacious. Because all this study, I can summarize here. Vestige is negative, Dante is ongoing, Matterhorn is kind of positive, K-Not pembrolizumab is positive, but not that much. I go quickly. This is Vestige. Vestige is nivolumab and ipilimumab. Can you please be silent just a little, because it's a big effort for me. You see, in the postoperative part, adding nivolumab and ipilimumab, it's a kind of adjuvant treatment. Unfortunately, it's even detrimental, if you can see here. So this arm, you see, this is the chemotherapy arm. This is the integration arm with nivolumab and ipilimumab. The other study, like Attraction, they didn't show any survival advantage. However, if you go to this more recent study, like Dante, where atezolizumab was used together with FLOT, and then surgery, and then FLOT with other 4 cycles together with atezolizumab versus FLOT plus placebo, you can see that the number of the regression rate in terms of MANDARD, you see tumor regression grade, who work with gastric cancer knows very well what is MANDARD regression rate. It's much higher when you add atezolizumab. We don't know if this will translate in overall survival improve, but I hope so, by the way. And this is the Matterhorn. This is the last study that's been presented last year at the ESMO meeting. The same situation with durvalumab plus FLOT versus placebo. The situation is exactly the same. You have the number of pathological complete remission. It's much higher when you had durvalumab to FLOT, but still we don't have strong data on overall survival. What do we know? It's the PD-L1, in this case, counts, because if you see the response in this forest plot, When PD-L1 is absent, less than 1%, there is no benefit. There's a higher benefit when it's more than 5% and more than one, and it's even a higher benefit when it's more than 5. So we need PD-L1 also in the perioperative setting. This is one of the keynote, it's pembrolizumab plus one of the combinations, cisplatin and capecitabine you see here. A similar regimen, doublet, triplet, and surgery, and then again the same treatment. And once again, higher pathological complete remission. Overall survival, yes. Event-free survival, but not enough. Didn't reach the statistically significant in the keynote you see here. So this is the forest plot also for this. What about HER2 in perioperative approach? Because we have patients, now we know that the patients are HER2 positive, so the temptation of treating the patient with FLOT or kind of regimen with trastuzumab is very high, because we say, I have a driver, why I cannot use the driver even in perioperative approach? Unfortunately, this study that was initially positive was closed early because the data you have heard before from the breast cancer colleague of Jacob were negative. Unfortunately, this study was stopped earlier, so we don't know if this approach was significant. We know in metastatic disease, you will see, but not in perioperative setting. So none of this drug now can be used together with FLOT. But what we can do, that just another, we say in Italian, cherry on the cake. We know that MSI-high tumors, they do not respond to chemotherapy. So this is another fight during the MTD meeting. What do I do with these MSI-high tumors? Do I treat with FLOT? But I know already they do not respond very well. And this comes from all the study, MAGIC study, classic, the adjuvant study, you know, and from meta-analysis with good conducted. So in this case, what do we do? I treat the patient with FLOT, but I'm very cautious because if it's a T1, for instance, even a T2, but no notes are sent to the surgeons. Let's see later if, even though it doesn't fit in these guidelines, the algorithm of ESMO. So you have to remember this. What we can do, we don't like FLOT, how we can improve FLOT? Let's use a chemotherapy regimen that is less, a triplet, that is less toxic. We know already for several years, but recently this has been emphasized by new studies, and it's the combination of capecitabine, so we replace 5-FU, oxaliplatin, and docetaxel. And you see in this study, of course, the number of the study is not as huge as AIO study, 91 patients. There is a benefit in terms of overall survival and progression-free survival in the arm treated with this combination that is less toxic than FLOT. You see here the numbers. The overall survival, 5-year overall survival is roughly around 60 months. You will see always this number, and 60 compared to 54, 55. And so this is the conclusion about that. So first of all, it's a context of a multidisciplinary approach. So you cannot decide on your own because there are many variables. There are many biological variables. I didn't talk about the nutritional assessment, but in many cases, the patient that you see in the clinic with a new diagnosis of gastric cancer, in particular if it's a upper, like, I don't know, the junction or lower esophagus, you have nutritional problems. So in many cases, you are tempted to treat the patient with jejunostomy or call the surgeons immediately and so on. So you have to be very cautious what you have in front of you, what is the benefit for the patient. We have, the good solution would be to have a good nutritional support from nutritional specialists, but I know even in my country this is not so common because it's something new. But by the way, you see that I'm still emphasizing the high volume centers, so the quality of surgery, it's not only, as I heard yesterday, margin-free, resection en bloc, number of nodes, you can call it like, it's the number of cases you treat every month or every year. If you operate one patient per month, so you have 15 patients per year, this is not a good quality surgery. You must operate at least, let's say, 30 to 40 per year. But there are numbers for that. In our curriculum, the surgeon residents, they have to finish the number of patients for every pathology, for every gastric cancer and so on. If they didn't operate at least, let's say, 30 to 40 patients, they cannot finish the course. So let's move quickly to adjuvant therapy, because there's not a lot to say about adjuvant therapy, unfortunately. What do we know? Classic, classic is from the Korean study. The Xelox is the worldwide standard now. However, there's a common use of capecitabine or 5-FU alone in this setting. From all the study, I'm reached 60. I remember Sargent study and the other study from the past. You know, it works. We don't know if it works, but we treat all the patients, even with 5-FU alone or capecitabine alone. There are many trials have failed, or even Italian trials with alternating doublets, triplets, and so on. We believe that probably we have to review this part of chemotherapy when we start using now less aggressive triplets. Let's say, let's replace 5-FU with capecitabine, and let's replace cisplatin with oxaliplatin. This has been done already in the British study with EOX, but not in the adjuvant setting, and probably there would be a benefit, let's see, because there are studies on that. There are studies also from this part of the world. You see, this is an adjuvant study with TEX triplet, of course, and the overall survival about 71 months. You can say, okay, this is a small number, we cannot translate in practice. But anyway, we know that this approach is feasible. Who will do the phase 3 with this TEX or DOC or whatever you want? We don't know. The problem is that companies, they are not interested in repeating a phase 3 in an adjuvant setting with all drugs. But it's interesting to understand that you can treat this patient also with this approach, especially if it's a very high-risk patient. You know, in many cases, for instance, you have a T2 and 3 patient, or T4 and 2 in your clinic. What you do for this? They are already metastatic. So the decision is, do I treat this patient as a metastatic setting, or I give to, so in this case, a triplet will be justified, or do I give to the patient a kind of, let's say, pseudo-adjuvant treatment? This is one case. Another study is a Chinese study. You know, China is doing a lot of trials. They do a good job, actually. With 300 patients, I don't go into details, but you see here there are several combination pre-op. By the way, you see that the overall survival is still around 60 months, and the number of patients is a little higher. And you have many trials, if you want to see with the, let's say, the depotentiation of FLOT or a triplet with drugs that they cannot give you an intolerable toxicity. This is one of the cases. There is also an Italian study, an Indian study. All of them, they have the same overall survival, the same disease-free survival with different group of patients. So in adjuvant treatment, these are the guidelines of ESMO. It's mandatory in any case for stage more than 1B to treat the patient in an adjuvant setting. It could be Xelox, it could be capecitabine, it could be 5-FU, it could be a triplet if it's a high-risk patient. But what is the role for radiotherapy in this setting? I don't know if my friend Alessio Morganti is here, but unfortunately, or let's say finally, they have lost a lot of position in the adjuvant setting, because when you have a good surgeon, like I would say the D2 gastrectomy, a well-staged patient, this is why I was insisting on the staging and biological and so on, and everything has been done the right way with a perioperative approach, surgery, right time, post-operative setting. You don't need radiotherapy. You only need radiotherapy when you have positive margins or R1, which means microscopical or macroscopical disease. This is the situation. Sometimes we don't do for R1, but there's an indication, by the way. So this is the standard of care in the adjuvant setting. Second question. Be ready to raise your hand. We have photo finish, we have pictures. Huh? In which setting of gastric cancer a more tolerable chemotherapy like triplet like TEX or DOC can be considered instead of FLOT? Adjuvant setting, metastatic disease, locally advanced disease, B and C, and selected patient A. Again. I mean, replace. Yeah. The lady in front of me, the colleague there. You. But it's not A, by the way. Let's say D. Look, B and C, we can do what we want. We can, because when we have a metastatic patient, you reduce the dose. You know, I never do FLOT 100% of doses. Never. I always do at least a 75 with some excuse. Oh, it's 70 years old, it's 75. Or,
Sir, the answer was wrong.
She was wrong, so let's choose another one. Right? You choose. So in many cases, we cannot give the full dose to the patient. So we can manipulate somehow this, the data of the trial, But we cannot do in adjuvant treatment. Either you do a treatment or you don't do, but because adjuvant treatment is based on level of evidence, you cannot give to the patient, oh, maybe it works. It's different because adjuvant is a patient that is potentially cured. So you cannot give to the patient toxicity that doesn't deserve. This is my personal comment. So let's move to the treatment of metastatic disease. Here the scenario is even more complex, you will see. But I hope I will do it very easy. This is the scenario until a couple of years, until 2 or 3 years ago. You see that we have best supportive care, we have doublets, we have the British suggestions of AOX, HEF, SEF, and so on. And finally, we arrived to the idea that we only need FOLFOX, like in colon cancer. If you ask me, why do we need FOLFOX? What is the real phase 3 that we follow? I don't even remember. Because even in colon cancer, ask yourself why we do FOLFOX. You check on the internet, on the literature, what are the phase 3. I don't say that I'm lacking, but it's not a huge study. Anyway, FOLFOX and Xelox is the standard, or Capox. But the problem in metastatic disease, let's anticipate this talk before talking about immunotherapy, is do we have to use a frontline triplet or doublet? This is has been a long fight during the year. And it's still a recent question. If you look at this, unfortunately, it's so crowded you're not able to read all the lines, but I will tell you. This meta-analysis, everything is in favor of a triplet, also for PFS and so on. It's not in favor of the triplet only when you use old drug like mitomycin. We don't use mitomycin anymore in gastric cancer. But let's say it's much better, it's better if you use a triplet from the beginning when you can. What does it mean when you can? For fit patient, young patient, when you cannot integrate the treatment because you don't have a biological driver. When you have a biological driver like HER2 or PD-L1, now there are other drivers arriving, I would say, the philosophy on using a triplet even in fit patient or young patient, it doesn't fit anymore. So it has to be reviewed. By the way, these are the data we have. These are the more modern study, the GAS-FOX and the DOCCG. And you see that in this case, this modification, as I told you, this modification of FLOT was gaining some point in terms of prolonging overall survival, although diarrhea, fatigue, and neutropenia was present. What is the problem of a triplet in metastatic disease? You are not able to give the right second line many times. Because if you use, like in colon cancer, if you use FOLFOXIRI or if you use FLOT, what do? You give docetaxel as second line with ramucirumab. It's a big issue somehow. Or you give irinotecan. Maybe you give irinotecan as a second line. These are the two studies, the Japanese study and another European study, a European-American study. They didn't show any advantage in terms of overall survival. Why? Because there was a high percentage of second line. We don't know, but it was not stated in the paper how many patients were treated in the second line setting in this study. But nevertheless, in Japan, this is the Japanese study, the regimen with 3 drugs was not able to improve overall survival. So that in the European guidelines, the 3 drug is not fully recommended. It's as I said, to be reserved to fit people, fit patients, biomarker negative. And when you are sure that you can use a second line, you are sure, or in any case, there are many centers where it's not easy to perform also second line, to give the second line to the patient. And regarding today I was hearing the discussion about guidelines. ESMO guidelines works a lot with the Japanese and Eastern Asia. I would be very glad if we would be able to work also with you with the guidelines you've been suggested today. And the PAGA guidelines is the adaptation for Asia of the ESMO guidelines. It has not been recorded that the benefit of overall survival. So it's not recommended at all. Once again, you have here the possibility to change this regimen of 3 drugs with a less aggressive drug. Here you have even more study if compared to adjuvant and neoadjuvant treatment. You have it here for, I don't go into details, but you have always a very good progression-free survival and overall survival, but the number of patients, of course, is a kind of phase 2 or little phase 3 patient and not, in most cases, not randomized. But by the way, you can replace it, and you have 50 months usually of overall survival and 6 to 9 months of progression-free survival. There are several examples, also one from India here. You see here that the response rate is very high, 63.5%, using the combination of capecitabine, oxaliplatin, and docetaxel. And the overall survival is a respectable overall survival, around 13 months if compared to the old regimens. Also, other study, I don't go into details, they have almost the same numbers. There is also an Italian study, and some of them it's more recent also. So last question regarding TEX, because we are in Synovia, so we have to do another question. Why might TEX or DOC chemotherapy triplets be favored over all the regimens like ECF or FLOT, lower cardiotoxicity, improved PFS and fewer side effects, oral administration of fluoropyrimidine, and no need of infusional pump? This point for me, it's absolutely crucial. And I tell you, before you answer, I travel very often. I'm consulted in other low and mid country. Yes, it is. I'm consulted in an Italian hospital in Albania. Albania is very close to Europe, as you all know. And, but unfortunately, it's a low and mid-income country. They are not able, most of the hospital, to provide infusional pump. So, you know, for us Italians, they always complain about everything, but everything is granted. You have to treat it with immunotherapy, is provided. Infusional pump, and this, everything is and we always say, oh, Italian health system doesn't work, and so you have to travel a little. By the way, this is an important point as far as I'm concerned. Of course, it's all of the above. So you don't know who's the winner, but it's all of the above. Let's move quicker to the other. This is the last part. Oh, sorry if you're bored, but this is the most important part probably. What happens after 2020? Finally, something has changed with the introduction of new driver like PD-L1 CPS. There's a long story about tumor mutation burden. I don't know who of you are working in translational research or labs and so on. Tumor mutational burden, it's not a driver. MSI is a driver, we will see. But for gastric cancer, the real driver, except two, it's PD-L1 CPS. And this study, I don't go into details of all of them. I only wanted to show you, this you will see also here, but I wanted to show you this part. These are the three studies that changed our practice, actually. And it's this, the Checkmate 649, the Keynote 589 in gastric cancer, and the Keynote 590 in esophageal cancer, either adenocarcinoma or squamous cell carcinoma. Why did they change the practice? So considering the first, don't consider the arm of nivo-ipi because it's been discharged very quickly, but there is highly significant benefit in all these three studies in terms of progression-free survival, overall survival, tolerable treatment, so that the ESMO AGI, you see here, approved. ESMO, the ME is the European Agency for Drug, approved in gastric adenocarcinoma, nivolumab, when you have a CPS PD-L1 more than 5, and pembrolizumab when you have CPS PD-L1 more than 1. Be careful, because this is a crucial point, more than 1, because the majority of patients are more than 1. So how a society can afford these big expenses to treat all the patients with gastric cancer with pembrolizumab? And there's some critics around this. And regarding esophageal and junction adenocarcinoma, it's almost the same. However, Japan, in my opinion, they did correctly. They left more than 10 CPS in esophageal cancer. I don't go into details of that because maybe you know very well. What is the real benefit derives from the PD-L1 expression. You see in all forest plot, in all meta-analysis. The problem is how much has to be this PD-L1? Has to be 1, has to be 5, or has to be 10? If you look at the study, there is a benefit. Let's talk about pembrolizumab. There is always a benefit starting from more than 1. But this benefit is higher and higher if you go to 1, to 5, to 10. So when you have in front of you a patient with more than 10, with 20, 30, say you are excited because this patient will respond. I will talk about that tomorrow also in immunotherapy, the intervention that I have to do tomorrow. When you have in front of you a patient more than 1, from 1 to 5, for instance, you have some resistance in giving to this patient a very expensive drug because pembrolizumab per month is kind of 6,000, 7,000 euros. So you multiply 4 the number of cycles we receive. So it's unbelievable in the number of patients. And although it is approved for more than one, there is some criticism from 1 to 10 or more than 10. Nivolumab is exactly the same, but in a different way. Less than 5 doesn't work. More than 5, it works, but it works much better if you have more than 20, more than 30, more than 40. So it's a big issue in the practice because the patient, they go always to Dr. Google. They know everything about that. They arrive, they sit in front of you. I want to be treated with pembrolizumab. Okay. So even if you explain, listen, maybe I can find a better solution for you. And no, immunotherapy is in the mouth of every patient, because they believe that it's less toxic. They are even disappointed when you tell them that you have to treat them also with chemotherapy. No, I want immunotherapy alone. So it's the way on the, it's a little complicated. By the way, this is the situation now. You see here, that if you look at as a ratio, this is keynote, which is pembrolizumab. Of course, it works with more than one. But if you look at the hazard ratio, it's 0.73. But if you look more than 10, it's 0.74. So it's something different. Let's move further. This data has been confirmed because you've seen is what 2020 in the longer follow-up. In the longer follow-up, when you have a higher CPS value, you have a longer duration of response. You have a longer progression-free survival. This is a crucial point because we don't know exactly, like in lung cancer, how many cycles we have to give to the patient. Sometimes I have to validate the therapy in my hospital because this is some duty we have to do once in a while. And I see patients that they receive 70 cycles of pembrolizumab, 50 cycles of nivolumab. So can you imagine how expensive this is for the health system? Because we don't know yet how many cycles. In lung cancer, it's even worse. So melanoma and kidney, maybe they deserve a long duration of the treatment. But in gastric cancer, we decide, at least for our regulation authority, to stop after 2 years. So we give to them 48 cycles and finish whatever it is, no matter if they are responding or not. What's new? I'm about to finish. There's another drug, there's a newcomer probably, new kid on the block. This is tislelizumab. Unfortunately, you cannot see here. Tislelizumab is another anti-PD-L1, but it has a different mechanism of action, different orientation, doesn't require PD-L1. And you will see there will be many surprises in the future because this drug is effective in terms of PFS and overall survival without PD-L1. So we go back, no driver at all. So we have to treat the patient with all the patients, no matter if they have PD-L1 or not. Let's see in the future because this is very risky. Another point, like we did in colon cancer, can we avoid chemotherapy when there is a very good response? I was talking yesterday with one of you. I don't remember his name. I don't have very good memory for Bangladesh names. It's intriguing. It's an intriguing question because, for instance, for FLOT, when you have a pathological complete remission in a neoadjuvant setting, or here, when you have a complete response, you didn't operate the patient, or you didn't give to the patient any kind of chemotherapy because maybe it was MSI high, you gave only pembrolizumab. What to do? You have to add chemotherapy. It's not like rectal cancer. If you have seen what happened in rectal cancer at the last ASCO meetings, the last 2 meetings, where they had a complete remission that lasted for more than 2 or 3 years, I don't think the gastric cancer is the same because the biology is different and it's very risky to stop without chemotherapy, even if it's MSI high. Do we add immunotherapy to a triplet? Probably yes. It's not the right time. Let's see what triplet we can use. Let's see why we have to do that. What do we know? It's according to ESMO guidelines, updated recently, September 2024. You give to the patient a triplet when you don't have a good when you have CPS score less than 1, when you don't have other driver, and when the patient is fit. This is room for other modification of triplet, also in metastatic gastric cancer patient. Just the few slides at the end. So MSI is a driver in any lines. So when you have a patient that has not been tested for MSI, almost much repair disease, in first line, you can do it in second line. There are always responses. There are always good responses. If there is a group of patients where I would spend money for immunotherapy is this. It's not PD-L1 from 1 to 5. And I will repeat this tomorrow because I was asked to talk about that. Okay, let's move this here. What about HER2? How we can improve HER2? Yes, we can improve HER2 because when you have HER2 positive and you have PD-L1 positive, we have more than 5 or more than 10, what to do? Who is the winner between the two drivers? So this study put together trastuzumab and pembrolizumab, and the study is actually positive. And the European guidelines probably will be updated. You see there is an improvement of overall survival and improvement of PFS when you do trastuzumab, pembrolizumab, and capecitabine, cisplatin, or Xelox. This will be another group of patients. Let's see. But this is an important point and a step forward also for a HER2 patient. Here is the declaration of ESMO. There's a new way to say, I don't know if I will register, if I will approve, probably yes. Adopts a positive opinion, okay? Some general observation. Let's move this further. Okay, we know that. So what's happened? What are the newcomers? Just the title. One is this. You remember the molecular classification. It's the Claudin 18.2. There's a new drug. It's called zolbetuximab, which will be approved. It's been approved in the first line anti-Claudin 0.8 positive patient. So you have another driver to include in that list, which is the Claudin. Are we able to do that? It's too expensive. Our efforts are enough? I don't know, but I saw the results of this study of zolbetuximab. They're quite interesting, actually. So when you don't have other driver like PD-L1 or HER2, and the patient has this driver, I think we have to treat it. I don't know what would be the cost or would be the way. It's a toxic drug somehow in terms of gastrointestinal toxicity. Let's see. The other newcomer, it's bemarituzumab. It's anti-FGFR receptor inhibitors. Actually, there's an embargo, but I'm one of the PI of the study, and I can tell you that is encouraging somehow. So let's see, this will be presented at the next ASCO meeting because we did a readout of the study. And the end, it's also an advanced disease. I don't go through second line, I just put the titles here. I remind you that we have options in second line. And we have also a new option. We have heard from the breast cancer presentation before with trastuzumab deruxtecan. So when you have a patient with HER2 positive in second line, now it's approved. Although there are some limit of toxicity and so on, trastuzumab deruxtecan with 30% of response rate in second line, some concern about lung toxicity, but we can do it very well. This we skip. So these are my conclusions. Gastric cancer is an important problem. You know, we believe that always colon cancer or pancreatic cancer is increasing a lot, gastric cancer and esophageal cancer. And so it's still a social issue. And the treatment is a treatment in a multidisciplinary context, always. Don't treat gastric cancer alone. Ask your colleague, what do we do? You will see the patient later. Do we operate? We don't operate. The only difference between gastric cancer and colon cancer is rarely you have the so-called incidental surgery. So if a patient is a good responder, gastric cancer, the biology of gastric cancer does not allow a lot of aggression in terms of surgery, but sometimes it happens. For instance, with peritoneal disease and PIPAC and HIPAC, you have heard the intraperitoneal administration of drugs. In metastatic disease, the driver is always HER2. I'm a little sick and tired of this HER2 because we don't know, for instance, if patients with HER2 or Claudin or FGFR2 receptors, they go better than the TOGA trial with the combination of trastuzumab, capecitabine, and 5-FU. There won't be a trial for sure in the future. We only know that we have to start from HER2. If HER2 is negative, we check for the others. The data with immunotherapy, PD-1 CPS, is they are outstanding, but remember that in certain point with low CPS, you don't have to expect a strong, a fantastic outcome, let's say. For patients that cannot be treated with immunocheckpoint inhibitors or HER2 inhibitors, we have this new trend to reduce the toxicity of FLOT or the triplet that we used in the past with replacing capecitabine, reducing the dose. And in my opinion, it works very well. You will see from the trials, there are the trials ongoing. I think I finished. I hope I was not too long. I hope I was clear, and I'm ready for questions.
Thank you, sir, for your amazing presentation. Now the floor is open for question and answer.
Any kind, also provocative. There should be some questions.
Very exciting and excellent presentation, Doctor.
Thank you.
I'm Dr. Lubna. I'm a clinical oncologist. So, have you any experience of perioperative neoadjuvant chemoradiation?
Actually, there have been several trials. Unfortunately, many of the EORTC trial was stopped earlier, because of low accrual, and for a simple reason. It was very hard to put together surgeons, radiotherapists, and oncologists. They didn't find an agreement. So they developed two different plans, and the study aborted. We don't use it because it doesn't deserve. I mean, the practice it's not in favor of this combination. In the post-operative setting, there is room still for radiotherapy. But if you look at the data of AIO, the German study in esophageal, for instance, which is typically the disease where you start with a chemotherapy approach. If it's severe, two or three, one, let's say, the upper. You can use cross with radiotherapy. This is the cross regimen, the correct approach. But this has been overcome by the data of AIO for adenocarcinoma, where FLOT is better than cross with radiotherapy. So the role became little by little less than the past. For esophageal squamous cell, of course, it's mandatory. I don't know if I answer.
Thank you, doctor, for your nice presentation. I have a question. For all cases we are planning for chemotherapy, should we go for MSI or MMR? For all cases we are planning for chemotherapy, because if MSI is high, we cannot give chemotherapy to those patients.
This is a question for a winner. I give you three answers because they told me that I have to add another question. When do you have to ask for MSI or mismatch repair deficient in a metastatic patient? A diagnosis, after progression, when you have a fit patient with somehow good condition and so on, or in a palliative disease, let's say in the third line. When would you do that? You have seen the MSI is a driver of any lines. So when would you do in your practice? It's an answer to your question. I will give you my answer later. No. Of course, yes, if you didn't do before. Actually, MSI, but you are the winner, by the way. MSI is, you have to know from the beginning. From the beginning. I know, even if you don't know from the beginning, I say not in adjuvant setting, metastatic setting, because in adjuvant setting, it's a prognostic indicator. It's not a driver for therapy. When you have MSI high, you have to treat the patient with immunotherapy, if you can afford, he can afford. Because the data we have with MSI high are much better with chemotherapy alone if compared to the combinations. But you can give also the combination. I was very fast in that slide. There was a slide with MSI high, with combination of chemotherapy and pembrolizumab alone. The data are exciting also with pembrolizumab alone. This is a case where you don't need chemotherapy from the beginning. You only need a progression of disease. So in my practice, we will do the diagnosis of metastatic disease immediately. The three MSI. So if I have the choice, I would do immunotherapy.
Another question is like that. In case of loco-regionally advanced, like stage 3A, if we are giving neoadjuvant chemotherapy, then what is your practice? After giving chemotherapy, neoadjuvant, are you going for laparoscopy, staging laparoscopy before surgery?
Actually, when we do laparoscopy, we do before deciding that this patient is a candidate to a perioperative approach. In surgery, sometimes they do, I'm not a surgeon, because they start with laparoscopy and they complete with the laparotomy, with the open access. But it's when you, when you have high volume and when you have the facilities, because you must have the surgeons who does this, it's not that easy, so you must be trained and so on. You might need the operation theaters. We do always at the beginning. So it's part of the multidisciplinary discussion. So the patients arrive in MTD meeting with laparoscopy, positive or negative. In that case, we decide, okay, you go to the oncologist or you go to the surgeon. I know it's an ideal situation, but...
Thank you so much for the excellent presentation. So you rightly said that we should know the MSI status from the very beginning. From the very beginning, not in the, only the metastatic setting, the MSI status. From the very beginning, not only the metastatic setting, in the early case as well. Yeah, so it's a very small subset of population, MSI high, but they are a good prognosis, have good prognosis, and the role of chemotherapy is quite controversial to this group. So my question is, in my country, a lot of patients undergo upfront surgery without having any chemotherapy. So after that, in adjuvant setting, if I find that the patient is MSI high, should I offer the patient adjuvant chemotherapy or not? MSI high, yeah.
Okay, this is a big issue, actually. It's a very good question. If you are in a context of colon cancer, you would have the answer immediately. The problem is this. For MSI high patient, there is a resistance to 5-FU and fluoropyrimidine.
Yeah.
There is no, or at least, there is a less resistance for oxaliplatin. So as you do for colorectal cancer, if you want to treat the patient with MSI high, you have to treat it even if it's an N0, T3 and 0, with Xelox or Folfox. It's the same for gastric cancer. If you want to use chemotherapy, you have to put the platinum compounds. But it depends, because at T3 and 0 or T3 micrometastasis, I wouldn't treat with any kind of chemotherapy in an adjuvant setting, because we know that doesn't work. So it's your idea to give to the patient the best, but it's not the best. We don't know if it works. Maybe you give some side effect, nothing else. For the preoperative staging, it's a long discussion there, because I don't agree with the figure of with the algorithm of ESMO that T1B has to be sent immediately in a perioperative approach, because T1B, MSI high, it's a different disease.
Yeah.
So you better operate immediately.
So
But you know, the guidelines are gentleman agreement decisions. It's not, this case is not based on a level of evidence. It's simply because in the IO study of FLOT, it was not included T1B. It's something that came later.
Thank you so much.
Excuse me, sir. I have one question. Okay, we are talking about MSI and things like that. Suppose a patient has come with MSI negative, that means not high. Okay, so we can give chemotherapy. But another investigation, DPYD, that is positive. Okay, so at that time, what should be our option?
Okay, I skipped some part because it was impossible. Otherwise, the preoperative, let's say all the exams you have to do at the beginning, they have to include also DPYD, because at least for deciding how much 5-FU or capsaicin you have to give to the patient. If you have an homozygosis, the DPYD, but it's not a driver of what to do in terms of neoadjuvant or not neoadjuvant. It's simply the driver of the dosage of 5-FU you have to give to the patient, because it ranges from 50% to 100%. And it's very common to give to the patient 75% or something like that. But in Italy, it's mandatory by the law, by the guidelines. So if you don't do that, you can be sued for this. So you have to do, it's not only DPYD, it's also UGT-A1A1 if you do irinotecan. 10 years ago, we didn't do that. But now the first things you do when the patient arrives, of course, you don't do UGT-1A1, but you do DPYD because it's part of the exams you have to do before starting chemotherapy. You can have, especially for adjuvant disease, because you can have very strong toxicity problems like diarrhea or neutropenia whatsoever. So if you don't do that, it's a big issue. But it's not a driver of putting the patient in one box or another.
Thank you, sir. Thanks a lot. So now I'll request Mr. Syed Abid Ahmed, Director, Marketing and Sales from Sanavia from our PLC, to deliver the vote of thanks. And right after the vote of thanks, we will be disseminating the gifts of our quiz winners.
Assalamu alaikum. Greetings from Sanofi Oncology. Distinguished guests, dear present professors, doctors, members of Oncology Club, Assalamu alaikum and very good evening. Actually, today's presentation by Carmelo Pozzo was fantastic. I saw everyone actually listening to him. So it was really rewarding. I believe it will be rewarding for all of us here. And so from the house, I would really like to thank Carmelo Pozzo. So shouldn't we give a very big applause for him? So I would like to thank Oncology Club for creating this fantastic platform for all of us so that we can disseminate the updates about treatment of cancer. So thanks actually everyone for your presence and make today's session successful. I would like to especially thank those who really worked to organize this program, today's program, especially the organizing committee, the technical committee, and all our support staffs. Without your support, actually, today's program would not be really a successful one. So I would like to thank our very dear Professor Hai to present here and, in fact, make this program glorious. So we look forward to meeting you all again in such fantastic session. Till then, Allah Hafiz. Good evening.
Thank you. Now I'll be announcing the winners of the quiz. So before I announce, I'd like to request Professor Dr. Eme Hai, sir, to come on stage and share the gifts with the winners. I'll request Professor Dr. A.M.M. Shariful Alam, sir, and Professor Hafiz Rahman Ansari, sir, as well, to come on stage and share the gifts with the winners. Dr. Carmelo Pozzo, please come on stage. And requesting Professor Dr. Mokhles Uddin, sir, as well, to come on stage. Tami, sir, and Ren Sabu, please come on stage and share the stage with us. Okay, so announcing the first quiz winner, the name is Lieutenant Colonel S.M. Rokunuzzaman, Department Head, Radiation Oncology, CMH, Dhaka. Winner number 2, Dr. Salwa Marwa, Resident, Radiation Oncology, NICRH. And the winner for the last question, it's I'll be requesting Lieutenant Colonel SM Rokunuzzaman sir again to come on stage because he's the only one who actually gave the answer for the third question, and it was correct.
সঠিক ছিল।
So now, before we close the session, we have another announcement that we very soon will be launching Paclitaxel in the name of Paxen. So for the first time, we'll be sharing the teaser video in front of you. So I'll request Professor Dr. M. A. Hai sir to play the video for all of us. So thank you everyone. Thanks a lot for coming, and it was a wonderful evening with you all, and hope to see you again in next year with something very new. Thank you. Assalamu alaikum.